All right. Hey, everyone. It's really good to see you for our August webinar here at Soul Mental Health. I see some new names as well as some familiar names. So thank you all for joining. As you know, today we're going to be chatting about one of our favorite topics in primary care and specialty care, which are benzodiazepines. Um, for the new names on the webinar, welcome. Just a quick overview on myself and Soul Mental Health. So I'm Arpan Parikh. I'm a psychiatrist by training, board certified in both general psychiatry and addiction medicine. I'm the chief medical officer at Soul Mental Health, which is a multi-site outpatient kind of comprehensive mental health group with practices across 6 states, including Colorado, New York, Texas, Washington, D.C., Maryland, and Virginia. We practice both therapy and psychiatry together under one roof, and we partner very closely with both primary and specialty care clinicians and groups in our communities to help them manage the psychiatric comorbidities of their patients. We've created this webinar series to speak to some of the challenges we often get questions about from our primary and specialty care partners, and hope that you'll come away from this with some really pragmatic and useful tips you can incorporate into your practice. You'll also have links at the end of this to earn some CME credits as well if you'd like to. So what are we going to talk about today? Uh, we'll start with just some basics so we're all on the same page around benzodiazepines. We'll start with an overview of the class, including the history, pharmacology, and pharmacokinetics. Now, we'll discuss some of the best practices for prescribing benzodiazepines in an outpatient setting, as well as some of the risks and adverse effects to really be keen on. We'll talk about how to taper and discontinue benzodiazepines in patients for whom they may not be the most appropriate treatment option, as well as how to think about and also message, safer and more efficacious options to patients. And then we'll end with a Q&A. You will also find a Q&A module in your Zoom. So as we're going through the talk, if you do have questions that come up, no need to wait until the end. You're welcome to drop the questions into the Q&A, and then I will pick them up as they come in and address them on the fly. So before we get into the nitty-gritty, let's just kind of set some background on benzodiazepines and kind of where they came from and also how they work. Benzodiazepines were discovered actually accidentally in 1955 by a chemist at Hoffmann-La Roche, which was and still is a Swiss pharmaceutical company. The compound that chemist discovered was chlorodiazepoxide, which we know today by its brand name Librium. And this was followed just 3 years later by the discovery of a related compound, diazepam, which we know today by the brand name Valium. Pretty quickly thereafter, these medications became very widely prescribed and used, and pharmaceutical companies realized the commercial value, so they began to invest much more heavily in R&D operations to discover new medications in the same class. About 15 to 20 years after that first group of benzodiazepines were discovered, we had clonazepam come to the market in 1975, and that was followed a couple years later by lorazepam. By the mid 1970s, benzodiazepines became the most prescribed class of medication globally. And that's not true anymore today. However, they are still generally in sort of the top 10 of most prescribed medications. So by no means are benzodiazepines not prescribed today, and we all know that anecdotally and from our own practices too. Uh, Rewinding everybody, pulling up a diagram here that might harken back to medical school or NP or PA training. Let's talk a bit about how benzodiazepines work in the brain. And this will become really important as we talk about some of the risks as well as what might be more effective in addressing the symptoms that we're trying to treat using benzodiazepines. So if you remember from your, physiology, specifically neurophysiology classes, we have GABA A receptors on neurons in the brain, in the central nervous system. These GABA A receptors are composed of 5 subunits, 2 alpha subunits, 2 beta subunits, and 1 gamma subunit. And you'll see in the bottom left of the diagram in the middle of the slide, kind of what that receptor looks like from a top-down view. So you got 2 alphas, 2 betas, and a gamma. This receptor is what GABA binds to kind of naturally in vivo in the brain, specifically the alpha and beta subunit. So GABA, which is a naturally occurring neurotransmitter in the brain, will bind to the alpha and beta sites. Benzodiazepines also bind to the same receptor in the brain, albeit to slightly different sites. So benzodiazepines will bind to the alpha and gamma subunits of the GABA A receptor. How do benzodiazepines work on this receptor? Benzodiazepines are allosteric modulators of the GABA A receptor. And again, bringing back some terms that may not have thought about since preclinical training, what that means is when a benzodiazepine molecule binds to the GABA A receptor, it increases the effect of GABA that binds to the receptor and potentiates the effect of GABA, which ultimately leads to the channel opening more frequently. This is a chloride ion channel. So the benzodiazepines increase the effect of GABA, which open the channel longer. This allows more chloride ions to flow from the extracellular side to the intracellular side. And if you recall how neurons work with action potentials, this influx of negatively charged ions results in the neuron becoming hyperpolarized. A hyperpolarized neuron takes more activation energy to fire, right? If you remember kind of the chart of what an action potential looks like in the brain. So functionally, what this means is the neurons that are affected and impacted by the benzodiazepines become harder to activate, which ultimately leads to CNS depression. And of course, central nervous system depression is the end effect and impact that we see clinically in a patient who's taking a benzodiazepine by design, right? That's how we're treating the symptoms that we're trying to address with the benzo. So again, just to kind of review this, because I know this slide is super, super dense. Benzodiazepines act on the GABA A receptors in the CNS. They are allosteric modulators, so they potentiate the effect of GABA on the GABA A receptors. This leads to hyperpolarization of neurons, which is the mechanism of action for causing CNS depression. What are some of the basic pharmacokinetics to be aware of with benzodiazepines? So we'll focus on PO administration here. They're well absorbed in the GI tract following PO administration. Of course, benzodiazepines can also be administered intramuscularly, but we'll kind of keep that on the side as that's not typically something that obviously is happening in an outpatient setting. Benzodiazepines are highly plasma bound. Most benzodiazepines are hepatically metabolized by the 3A4 and 2C19 routes. There are 3 exceptions, which include lorazepam, oxazepam, and temazepam. This is a really clinically relevant point. If you are treating a patient who has hepatic insufficiency, any kind of hepatic disease, we want to typically avoid any of the hepatically metabolized benzodiazepines. So in a patient with liver disease or hepatic insufficiency, if we decide that a benzodiazepine is clinically indicated, we probably want to use, all else being equal, lorazepam, oxazepam, or temazepam, because their metabolism doesn't run through the liver and their clinical effect will be much more predictable. Because if we use one of the hepatically metabolized benzos, it can be challenging in patients with hepatic insufficiency to know how quickly the body is going to clear it. And typically what ends up happening is the benzodiazepines have a much longer lasting effect on the patient. And then in terms of excretion, benzodiazepines are primarily excreted renally. So again, in patients who have significant renal insufficiency, it's important to be careful with dosing benzodiazepines because they actually may not clear it out of their system as quickly as a patient who has a well-functioning liver. Sorry, kidney. So as we think about time to clear and elimination half-life, I think it's important for all of us to be on the same page around the subclasses of benzodiazepines because they're not all created equally. And the way I like to think about them in terms of subclasses is arranging or organizing by their half-life. And I would think about three major buckets of benzodiazepines. So we have kind of short-acting, mid-acting, and long-acting. And I would focus that categorization based on the fourth column here, which is the elimination half-life. So in the short-acting bucket, I would include primarily oxazepam and alprazolam. In the mid-acting bucket, I would include lorazepam and temazepam. And then all the rest I would consider to be long-acting, which include chlordiazepoxide, clonazepam, and diazepam. These categorizations are super important because as we think about potentially discontinuing benzodiazepines, it can be much smoother and more comfortable for patients to taper off of long-acting benzodiazepines than short-acting. So, one strategy we can use clinically in patients who we're trying to discontinue benzodiazepines for is move them initially from, say, an alprazolam or an oxazepam to something like a clonazepam or diazepam, because those tapers are much, much smoother given the longer half-life of those benzodiazepines. So now that we know a bit about where benzodiazepines came from, how they work in the brain, how they're metabolized, and how to categorize them, I'd like to shift our conversation to, when is it appropriate to use a benzodiazepine, and when might we consider benzodiazepine use to be suboptimal? What you see here on this page is, from my perspective and kind of from the perspective of psychiatrists, like what are appropriate uses for benzodiazepines. I've organized them in a way in which kind of the top two are what you might utilize or what might be appropriate in an outpatient primary care practice. And then all the rest are what I imagine are use cases that aren't super relevant to outpatient primary care and are more used by specific specialists or in the inpatient setting. So, going one by one here, certainly it is appropriate and there's, good literature backup for the use of benzodiazepines in very acute episodic anxiety and panic. So an example there is a patient who has very, very specific anxiety related to, say, traveling on a plane and using a medium-acting benzodiazepine, one or two tablets to help a patient feel more comfortable while they're traveling on a plane. There's also good literature and clinical use base for benzodiazepine prescribing for symptomatic relief when starting an antidepressant. So as you may know, when we start an antidepressant, typically that entails a 4 to 6 ramp to full therapeutic effect. During that 4 to 6 week period, number one, the patient may still continue experiencing the underlying clinical symptoms that we're trying to address with the antidepressant. Let's say maybe anxiety in a patient with anxiety disorder. Secondly, the side effects of antidepressants, they don't wait 4 to 6 weeks to kick in. Those side effects can start as early as week 1. So in a patient who's anxious and continuing to experience anxiety and maybe having some side effects from an antidepressant, while they wait for the efficacy to kick in around week 4 to 6, it can be helpful to have a short, time limited, and dose limited course of benzodiazepines to help them make it through that initial period of time. What's really important in those situations is being very clear and upfront with patients and setting expectations around how much they can use the benzodiazepine, and that it truly, truly will be dose limited and time limited. And once the antidepressant has reached its full efficacy, that benzodiazepine will not be refilled or renewed. Now, to be totally candid, that is sort of where the legitimate and safe and efficacious use cases for benzodiazepines in an outpatient setting ends. There are a few other settings or clinical situations when we use benzos. Of course, they can be helpful in managing seizure disorders, including status epilepticus. They can be very effective and safe in managing, acute alcohol withdrawal, and particularly the long-acting benzos like chlorodiazep oxide are very efficacious. Of course, we can use benzodiazepines to treat acute benzodiazepine withdrawal, as well as acute barbiturate withdrawal. They can be very useful in treating catatonia, which can be a sequelae of severe mood disorders and more commonly severe psychotic illnesses. And they can also be efficacious in treating acute mania as well as acute psychotic agitation. So now that we chatted a bit about when it's safe and effective, and it could be, recommended to use a benzodiazepine in the outpatient setting, when do we as psychiatrists see benzodiazepines used suboptimally in outpatient settings? Number one is monotherapy. We'll chat more about this shortly, so I'm not going to spend a ton of time here. But what we'll talk about is benzodiazepines. We should really be thinking about them as symptomatic treatments and not disease-modifying agents. So, long-term monotherapy with a benzodiazepine shouldn't be a typical use case. And number two, subacute anxiety and chronic anxiety. And again, the reasoning there, which we'll talk a bit more about, is these medications are not disease modifying, and we'll chat a bit about how they can actually make anxiety presentations worse if used alone. And then finally, insomnia. And again, this is a really frequent use case that we often see in outpatient psychiatry. Unfortunately, for similar reasons, monotherapy of insomnia with the benzodiazepine often misses the underlying cause for the insomnia and does the patient more harm than good. So, why are benzodiazepines not the best idea for monotherapy for subacute or chronic anxiety or for insomnia? So going back to our trusty GABA A receptor, we know that benzodiazepines act on the alpha and gamma subunits to potentiate the impacts of GABA and lead to hyperpolarization of neurons. They act in a very similar way to another substance. I'll pause here for 10 seconds and you see I put a diamond with a question mark. So there's a very commonly used molecular substance that acts almost identically to benzodiazepines on the GABA A receptor. This molecule only potentiates on the alpha subunit. If anyone has a guess as to what that molecule is, drop it in the Q&A or the chat. I'll wait 20 seconds here to see if anyone has a guess. Okay. No guesses, which is okay. So the molecule that actually acts almost identically in the central nervous system as benzodiazepines is actually ethanol. Uh, so what does that mean? That means functionally, every time we prescribe a patient a benzodiazepine, what's happening in their body or what's happening in their brain is identical to what happens in the body, or specifically in the brain, when a patient ingests ethanol, i.e., they have an alcoholic drink. So in some ways, in a somewhat rudimentary sense, you can consider and should consider benzodiazepines to essentially function as freeze-dried tablets of alcohol. And I often use this analogy when I'm speaking and discussing this with patients, is yes, benzodiazepines are, FDA approved pharmaceuticals, and yes, they have their clinical use cases. But in many ways, taking a benzodiazepine in the way they impact the brain is the same and can be thought of as, taking a freeze-dried shot of tequila or a freeze-dried shot of vodka. And I think we can all agree that if we're trying to treat insomnia or trying to treat chronic anxiety, we would never suggest a patient to take a shot of tequila every night to help them go to bed, or take a shot of vodka every time they feel anxiety during the day. So I hope that analogy helps, number one, us better conceptualize what these medications actually do in the brain. And number two, gives you some language you can use with patients who might have some hesitation or some resistance to, this idea of using non-benzodiazepine options. Secondly, uh, if we take this concept one step further, using medications like benzodiazepines that are global CNS depressants to treat illnesses and presentations like chronic anxiety and insomnia, they prevent the patient from actually addressing and processing what may be the underlying root cause of those symptoms. So, for example, a patient who has trauma and as a result has difficulty going to sleep, taking Klonopin every night to help them get to bed, and maybe that Klonopin works for some period of time, it may be actually preventing the patient from going and getting to the root cause, processing the trauma with a psychotherapist, developing the coping tools and mechanisms to actually help them get to sleep in a much safer and more sustainable way. So what are some of those specific risks and side effects that we have to be really careful about and mindful of when prescribing these medications? Number one, these medications are very prone to causing respiratory depression and respiratory arrest, particularly in patients who have underlying cardiopulmonary disease. Number two, they can cause drowsiness, which of course sometimes is the intended clinical effect. But we want to be really careful with patients when they're first starting a benzodiazepine to, counsel and instruct them on the potential for drowsiness, especially if, they are someone who drives vehicles or operates heavy machinery frequently. Don't take the medication for the first time right before you get behind the wheel of a car or a forklift. Take it when you're at home and when you're monitored so that you have a good sense of how it impacts your body. These medications can cause confusion and syncope. Of course, they can have synergistic interactions with other substances that work on the GABA A receptor, so alcohol, other benzos, and barbiturates. Misuse is very possible with benzodiazepines. That can lead to dependence. And as we know, dependence is a physiologic term, which means that a patient can get to a place where not taking a benzodiazepine can cause physical withdrawal symptoms. They can also potentially lead to substance use disorder, which is kind of the psychological corollary to dependence, where patients start to exhibit sort of maladaptive behaviors to obtain and use benzodiazepines in the pursuit of avoiding withdrawal. And there's one contraindication and one black box warning to be aware of. So there's an absolute contraindication in patients with angle closure glaucoma, and there is a black box warning for combining with opioids. So uh, combining a benzodiazepine with an opioid, which is relatively common sense, can lead to sedation, severe respiratory depression, coma, and potentially death. So if we're prescribing a patient a benzodiazepine, it's critically important to get kind of a full medication history and, of course, look at the uh, prescription drug monitoring program for your local state so you can ensure you know exactly what other controlled substances, including opioids, a patient might be taking. So now that you know some of the risks and potential challenges with benzodiazepines, how do you go about, tactically tapering and discontinuing a benzodiazepine for a patient who comes to you on one or you've been prescribing one for some period of time? As we talked about earlier, it is generally easier, more comfortable for the patient, and safer because it reduces the risk of acute withdrawal to taper long-acting benzodiazepines versus short-acting benzodiazepines. So if possible, and if tolerated by the patient, consider switching them to one of the longer acting benzodiazepines and then start the taper. You'll have a higher chance of success that way. When I think of a typical taper schedule in the outpatient setting, I will aim for about 25% dose reduction per week. And I'll often meet with these patients on a weekly basis. Number one, so I can, assess their withdrawal risk and understand if we're going too fast in particular. But number two, to provide just support because this is a challenging process for patients. And meeting with them weekly or biweekly can help provide that reassurance and also potentially symptomatic relief to keep them strong and keep them kind of committed to the taper process. Um, for patients where I want to pursue a more conservative schedule, typically what I'll do is do the 25% in week one, but then slow down and do something closer to 5 or 10% dose reduction every 1 to 2 weeks thereafter. Um, it's always a good idea to utilize non-benzodiazepine symptomatic reliefs to support patients during this time. So, if they're having headaches, if they're having nausea, vomiting, body aches, etc., utilize the appropriate symptomatic PRN medications to help them feel more comfortable. And then finally, for patients who are exquisitely sensitive to the tapering process, one strategy you might consider is pausing the taper once they reach about a 50% dose reduction for 1 or 2 months. Um, and then also going very, very slowly as you approach the end of the taper. That last kind of 10 to 15% can be very, very difficult and challenging for patients to taper off of. And I think what's important in those situations from a clinical perspective is to give patients grace. If they've reduced their dose by 90%, that's an amazing reduction and that's fantastic progress. Um, there's no need to rush unless there is a really strong clinical indication to do so. That last 5, 10, or 15%, work with the patient, ally yourself with them, and work through that last little bit. So you've had the conversation with a patient about potentially using a medication other than benzodiazepines. What can you use instead? So I would love everyone to come out of this webinar that really thinking of benzodiazepines as truly symptomatic treatments, unless you're using it, to treat catatonia or acute mania or acute benzodiazepine or alcohol withdrawal. My guess is not many of you who are in the primary or outpatient specialty care world are treating those clinical presentations. They may help cover up a patient's symptoms in the short run. But in the long run, number one, they can create problems themselves, as we reviewed kind of the risks and adverse effects. And number two, they can actually prevent or delay the addressing of the underlying pathology. maybe one analogy we can use here is, for the primary care clinicians who are on this call, imagine a patient comes to you with a chief complaint of a fever. Um, in that situation, recommending or prescribing the patient an antipyretic, let's say Tylenol, and telling them to go home, take Tylenol around the clock every 6 hours in perpetuity, and that'll treat the fever. I think we could all agree that that would be not great clinical practice, and that might even border right on malpractice. Uh, a patient presenting to a primary care office with fever, like we ought to do the right workup for the fever, and we ought to figure out what's causing the fever and then actually treat the underlying cause. Sure, taking an antipyretic to treat the fever itself could be one part of the strategy, but that's never going to actually heal the patient. So think about benzodiazepines in that exact same framework. A patient presenting to your office with anxiety or insomnia, sure, short duration, medium or long acting benzodiazepine to provide symptomatic relief may very well be an okay time limited strategy. But it's not good clinical practice, and it certainly isn't malpractice, but it does do the patient a disservice if we don't do the right workup and help figure out and understand what's actually driving that presentation and get the patient to the right place, specialist, or treatment to deal with that. So in this situation, for the patients who often are prescribed benzodiazepines in perpetuity, patients who have anxiety or insomnia, think of the disease modifying agents as really two classes of treatment. We have psychotherapy and we have antidepressant therapy. Those are really the two gold standard first line treatments that we should think about. Uh, how can we support patients in this journey? So, as we, let's say, have a conversation with a patient about getting off of a benzodiazepine, we've talked about a tapering schedule, we've discussed the alternatives. It can still be a tough pitch to make to a patient. Remember, number one, patients may have developed a physiologic dependence to the benzodiazepine, and they may have also developed a psychological attachment to the medication. Um, I'm going to share with all of you kind of one strategy and one analogy I've developed over the course of my career. I've tweaked it and refined it a little bit, but I found it to be really, really helpful in explaining my rationale to patients. And I give everyone here full license to use this in your clinical practice if you find it helpful. Um, I call it the leaky sink analogy. So if I have a patient in my office and we're having a conversation about switching or helping them get off a benzodiazepine onto a disease modifying agent, it's not really helpful for me to describe to the patient this concept of symptomatic treatment versus disease modifying agent, getting to the root cause. What I've found to be much more helpful is relating it to an analogy that is much more digestible to the patient. So the analogy I use with my patients, and we'll pretend maybe that you, the audience here, is a patient in front of me. It goes something like this. Think of your anxiety as a leaky faucet in your kitchen. Using a medication like Klonopin to treat the anxiety is like putting a bucket underneath the leak in your kitchen sink, as demonstrated by this picture. Uh, in the short run, that bucket helps catch the water, and that water is your anxiety. So the bucket works, right? It catches the water, it keeps the floor clean, it keeps the cabinets dry, and things seem okay. But with every hour and every day that passes, the bucket gets closer and closer to getting full. And eventually that bucket gets completely full and starts overflowing. And now when you go to pick up the bucket to, empty it so you can put it back under the sink, it's full of water, it's sloshing everywhere. It makes a really big mess, as you walk from your kitchen to the back door to empty it out. And as it overflows, the water gets all over your floor, it gets all over your cabinets, and it actually makes the whole situation worse. That's not what we want to happen to your anxiety. So instead of using a bucket, i.e., Klonopin, to treat your anxiety, let's figure out how we can stop the leak in the first place. And in the case of this leaky kitchen sink, I think we can all agree that what we would do is maybe we put the bucket under the sink for an hour, but we're going to go and call our favorite plumber. And the plumber is going to come into the kitchen and they're going to get underneath the sink and they're going to find, the connection that's loose and they're going to fix that pipe. And think about these other medications that we call antidepressants as the plumber, because these medications, antidepressants, and also psychotherapy, they're going to work in the brain to actually stop the leak, i.e., they're going to stop the anxiety. And we won't have to use that bucket anymore to catch the water. So that's a little bit of a tedious exercise for us to walk through, but I hope that gives you maybe a good talk track that you can adapt and use with your patients as you try to work through with them kind of the clinical rationale, the why behind, switching from a symptomatic treatment like a benzodiazepine to a true disease-modifying agent like an antidepressant or psychotherapy. And we just kind of reviewed this in terms of what to use instead. The literature and the clinical evidence it's really, really clear and very straightforward here. For the presentations in which we're most often using benzodiazepines in the outpatient setting, which tend to be anxiety presentations and insomnia presentations, that treatment, if we're going to approach it from the disease modifying perspective, should actually include some combination of psychotherapy and antidepressant therapy. We know either one is great and works really well in treating anxiety and insomnia, but we also know that combining them together results in the best outcomes for patients. So a quick recap on what we reviewed today. Number one, benzodiazepines were actually discovered accidentally, like so many medications that we use today, in the mid-50s, and quickly became the most prescribed medication class globally, and they held that position for decades. Number two, benzodiazepines function in the central nervous system as allosteric modulators of GABA A receptors that potentiate the effects of GABA to ultimately cause a global CNS depression. Number three, there are very limited safe and effective use cases for benzodiazepines in the outpatient setting. But really, there should only be two use cases in the typical outpatient, primary or specialty care setting for a benzodiazepine. Number four, would love everyone, if you have one takeaway from this, is think of benzodiazepines as purely symptomatic treatment. In the same way, none of us would ever treat, again, a fever with just Tylenol and nothing else. Think of prescribing a benzodiazepine for insomnia as treating a fever with Tylenol and never actually working up the fever and treating the underlying infection. In contrast, think of antidepressants and psychotherapy as the true DMARDs, disease-modifying agents. And number five, which I just mentioned, is the gold standard treatment for most of the indications that benzodiazepines end up getting used for are number one, psychotherapy, and number two, antidepressant therapy. Either one is great on its own. And if we can combine both together, the data is clear and that outcomes will be even better in combination. So for all of you who attended and registered, you can earn one total AMA Category 1 CME credit. We'll send an email out after this with number one, a recording of this, number two, a copy of the slides, and number three, links so you can get your CME credits. And we have about 15 minutes left. I'm happy to stay on here for any question and answer. So if anyone has a question, feel free to drop it into the Q&A. And otherwise, it was good to see everyone and hope to see you on the next webinar.